Halo, selamat siang semuanya. Kita akan memulai webinar pada hari ini, pada tanggal 22 Februari 2025. Sebelumnya, Assalamualaikum warahmatullahi wabarakatuh. Selamat siang dan salam sejahtera untuk kita semua. Yang terhormat para narasumber yang telah bergabung dalam webinar ini, yang saya hormati rekan-rekan sejawat, dokter, perawat, dan seluruh peserta webinar, serta tak lupa seluruh tim panitia yang telah bekerja keras menyiapkan webinar ini. Izin memperkenalkan diri, saya Mega, akan bertugas sebagai MC pada webinar kali ini. Sebelum kita memasuki webinar inti, izinkan saya untuk menyampaikan sedikit pengantar. Webinar kita hari ini mengangkat topik yang sangat penting dalam dunia medis, khususnya di bidang perawatan intensif, yaitu Management of Acute Kidney Injury in ICU, Continuous Renal Replacement Therapy using Regional Citrate Anticoagulant. Seperti yang kita ketahui, akut kidney injury atau cedera ginjal akut adalah kondisi serius yang sering dijumpai di ruang ICU, dan penanganannya memerlukan pendekatan yang tepat, serta teknologi yang mutakhir. Salah satu terapi yang akan kita bahas adalah Continuous Renal Therapy Replacement Therapy atau CRRT dengan menggunakan antikoagulan citrate. Webinar ini sendiri akan dimoderatori oleh Profesor Dr. Dita Adityaningsih, spesialis anestesi KIC, dan kita juga akan mendengar langsung dari para narasumber, Dr. Mayang dan Dr. Albert Fu, yang memiliki pengalaman serta pengetahuan mendalam terkait topik ini. Semoga diskusi hari ini dapat memberikan wawasan baru, memperkaya pengetahuan kita, dan tentunya bermanfaat bagi praktik klinis sehari-hari. Sebelum sesi webinar dimulai, mari kita mendengarkan sambutan dari Dr. Erwin Pradian, spesialis anestesi, subs anestesi regional MKes, selaku presiden dari Perdici. Kepada Dr. Erwin Pradian, waktu dan tempat kami persilahkan.
Ya, terima kasih, Mega. Pada yang terhormat, para guru-guru, senior, serta sejawat dimanapun Anda berada, serta Bapak Ibu peserta webinar yang saya banggakan. Assalamualaikum warahmatullahi wabarakatuh. Salam sejahtera bagi kita semua. Pada kesempatan ini pertama-tama marilah kita panjatkan puji dan syukur kehadirat Allah Subhanahu wa Ta'ala yang berkat rahmat dan ridhonya kita dapat berkumpul dalam webinar ini dalam kondisi sehat walafiat. Pada kesempatan ini pula, saya ingin menginfokan bahwa kegiatan webinar ini adalah suatu kegiatan webinar serial yang akan kita laksanakan pada hari ini dan esok hari, dalam rangka memperingati Hari Ulang Tahun Perdici yang seyogyanya jatuh pada tanggal 28 Februari setiap tahunnya. Akan tetapi karena berbagai hal, khususnya kita sudah akan masuk ke bulan Ramadan, maka kita putuskan untuk memajukan acara ini menjadi hari ini dan esok. Dan pada kesempatan ini kita akan melakukan satu kegiatan webinar yang khususnya sesuai dengan visi misi kita sebagai organisasi dokter intensif care Indonesia, yaitu visinya adalah meningkatkan layanan ICU di Indonesia. Maka pada kesempatan ini kita akan melakukan webinar dalam rangka meningkatkan pengetahuan dan teknologi khususnya tentang continuous renal replacement therapy di ICU. Saya juga ingin mengucapkan terima kasih pada narasumber yaitu Dr. Mayang dari Universitas Sriwijaya Palembang. Kemudian I would like to thanks to Dr. Albert Seufu from Wuhan, China. Thank you for joining us. Dan yang ketiga sebagai moderator adalah Profesor Dita Adityaningsih dari Rumah Sakit Cipto Mangunkusumo dan FK Universitas Indonesia. Terima kasih. Semoga apa yang sejawat lakukan pada hari ini akan menjadi dan amal bagi sejawat semua. Dan yang terakhir, saya ingin mengucapkan terima kasih kepada Fresenius Medical Care beserta tim yang sudah mensupport acara-acara kami, khususnya pada hari ini, dan kepada seluruh peserta sejawat semua, selamat mengikuti webinar ini. Semoga apa yang sejawat-sejawat lakukan pada hari ini akan memberikan kebaikan bagi kita semua. Sekian dan terima kasih. Wabillahi taufiq wal hidayah. Wassalamualaikum warahmatullahi wabarakatuh.
Terima kasih kepada Dr. Erin Padian. Selanjutnya, mari kita dengarkan webinar inti kali ini kepada Profesor Dr. Dita Adityaningsi, spesialis anestesi KIJ. Waktu dan tempat kami persilahkan.
Terima kasih. Assalamualaikum warahmatullahi wabarakatuh. Saya ucapkan terima kasih kepada Perdici yang telah mendukung untuk diselenggarakannya webinar pada hari ini. Dan terima kasih juga kepada Fresenius yang telah mensupport acara webinar kali ini. Dengan topik Management of Acute Kidney Injury in ICU, Continuous Renal Replacement Therapy using Regional Citrate Anticoagulan. Pada kesempatan kali ini kita ada dua pembicara, di mana pertama adalah Dr. Mayang Indah Lestari ya. Mungkin bisa di-share CV-nya untuk bisa saya bacakan. Dr. Mayang ini menyelesaikan pendidikan mulai dari dokter, spesialis anestesi di Fakultas Kedokteran Universitas Sriwijaya. Dia juga menyelesaikan konsultan intensive care-nya pada tahun 2020 di Universitas Indonesia. Dan terakhir dia juga sudah menyelesaikan program doktornya ya, program doktoralnya di bidang biomedik tahun 2024 di Universitas Sriwijaya. Saat ini Dr. Mayang adalah staf dan dosen di Departemen Anestesi dan Intensive Care di Universitas Sriwijaya, Rumah Sakit Muhammad Husin Palembang. Saya persilakan kepada Dr. Mayang untuk memulai presentasinya yang berjudul Acute Kidney Injury and Renal Replacement Therapy, a Systematic Review. Silakan Dr. Mayang.
Yes, thank you for the introduction, Prof. Dita, my teacher. Prof. Dita, thank you once again. I would like to share my presentation first, but I apologize to Dr. Albert Fu that I will speak in Bahasa. Oke, Assalamualaikum warahmatullahi wabarakatuh. Selamat siang semuanya. Yang saya hormati Dr. Erwin Pradian, Ketua Perdici, segenap panitia, dan para hadirin yang berkenan hadir pada presentasi kami pada siang hari ini. Baik, saya akan mempresentasikan sebuah telaah sistematis yang kami baru saja lakukan yang berjudul Acute Kidney Injury and Renal Replacement Therapy. Jadi sebagai latar belakang, kita ketahui bahwa sampai saat ini guideline yang berlaku untuk acute kidney injury atau AKI itu masih adalah KDIGO 2012. Dan guideline ini mengambil data-data penelitian sampai tahun 2011 Februari. Padahal setelah tahun 2011 ini banyak sekali studi-studi yang mengangkat tema atau topik penelitian mengenai AKI dan renal replacement therapy. Dan dari guideline yang ada saat ini itu tidak spesifik untuk pasien-pasien kritis yang kita rawat di ICU. Maka kami melakukan TA sistematis dengan topik ini. Jadi ada beberapa pertanyaan yang kita akan jawab pada akhir dari telaah sistematik ini, yaitu apa saja sih karakteristik pasien ICU dengan AKI dan menjalani renal replacement therapy, kemudian bagaimana akses CDL yang dipasang, akses untuk dialisis yang dipasang, kemudian kapan memulai RRT, kemudian modalitas apa yang dipakai, kemudian antikoagulannya apa, kemudian kapan kita mewinning atau menyapih dari RRT, dan bagaimana outcome dari pasien kritis dengan AKI yang mendapatkan RRT tersebut. Nah, jadi setelah sistematis ini kami buat dengan mengacu pada guideline Prisma 2020 Preferred Reporting Items for Systematic Reviews and Meta-Analysis dari 2 database yaitu PubMed dan Science Direct dengan studi restriksi fokus pada RCT, cohort, dan case control. Dengan time restriksinya adalah studi-studi 5 tahun terakhir, yaitu dari tahun 2020 sampai tahun 2025. Dengan bahasa Inggris, full free access, dan pada pasien yang dirawat di ICU. Ini data yang kami ekstrak, jadi ada autornya, tahun, country-nya, kemudian karakteristik subjeknya, kemudian ada CDL access, time to RRT, modality of RRT, kemudian renal dose, anticoagulan, dan outcome. Ini studi selection flow, jadi dari 88 studi yang ada di PubMed database dan 35 yang ada di Science Direct, kita keluarkan 2 karena ditarik dari author-nya. Kemudian dari yang ada itu kemudian kita exclude lagi karena ada yang tidak sesuai berdasarkan title dan abstrak. Kemudian kita cek lagi apakah ada duplikasi, kemudian apakah ada yang tidak memenuhi kriteria inklusi atau topik yang tidak relevan, maka kita juga keluarkan dan akhirnya kita dapatkan 27 studi yang relate. Nah, dari 27 studi ini 26 populasinya adalah dewasa dan 1 pediatrik. Dari studi yang pertama tidak disebutkan bagaimana karakteristik subjeknya. Dari studi yang kedua, dari Barbar dan kawan-kawan, tahun 2023, karakteristik subjeknya adalah pasien CKD, kemudian hipertensi, diabetes dengan CAF, kemudian dengan penyakit pernapasan kronis, kemudian penyakit hati kronis, dan pasien dengan imunosupresif. Pada studi ketiga didapatkan pasien dengan hipertensi, diabetes, coronary heart disease, aritmia, pasien dengan CPD, COPD, pulmonary tuberculosis, pasien dengan chronic kidney disease, dan hepatitis viral. Kemudian juga ada pada pasien post-op cardiac surgery, kemudian ada pasien dengan aortic dissection, kemudian ada pasien dengan chronic kidney disease, chronic hypertension, diabetes mellitus, CHF, cirrhosis, respiratory disease, cancer, AIDS, immunosuppressive drugs, organ transplantation. Berikutnya dari studi nomor 7, pasien dengan DM, hipertensi, CKD, penyakit hati, penyakit jantung. Pada subjek yang ke-8, pasien dengan DM, hipertensi, obesitas, pasien dengan CPD dan COPD. Pada subjek yang ke-9, pasien dengan sepsis, hipovolemi, dan gagal jantung. Pada subjek yang ke-10, pada studi yang ke-10 didapatkan subjeknya itu memiliki karakteristik dengan hipertensi, DM, CKD, miokard infark, CHF, dengan penyakit vaskular perifer, CVD, demensia, dan seterusnya. Dan rata usianya ini adalah lebih dari 50 tahun ya. Jadi older age. Ini hampir sama untuk comorbidity-nya. Rata-rata pasien dengan comorbidity penyakit yang kronis, metabolik, kardiovaskular, kemudian dengan imunosupresif, pasien dengan problem di CVD, problem di paru, dan seterusnya. Dan ada satu penelitian pada pasien anak-anak, namun di sini tidak dijelaskan bagaimana comorbidity atau karakteristik subjeknya. Nah, masuk ke pertanyaan yang berikutnya adalah mengenai venous of choice for sedal access. Jadi dari guideline kita ketahui bahwa first choice-nya adalah vena jugularis sebelah kanan. Diikuti dengan vena femoralis, kemudian vena jugularis kiri, dan subclavia terutama di tangan yang dominan ya. Karena yang tidak dominan itu akan dipakai untuk aphasia. Nah, bagaimana studi 5 tahun terakhir ini kita dapatkan satu studi yang menyatakan bahwa yang paling sering itu adalah akses di vena jugularis interna sebelah kanan, dan ini sesuai dengan rekomendasi dari KDIGO. Lantas bagaimana untuk waktu, time to start RRT? Jadi di sini ada beberapa studi yang kami ambil yang relate dengan tujuan penelitian ini. Yang pertama adalah dari Barbar dan kawan-kawan tahun 2023 bahwa kelompok yang kita lakukan RRT secara dini itu angka kematiannya 58%. Dan pada yang late itu 42%. Hal ini menunjukkan bahwa tidak ada perbedaan antara yang early maupun yang late. Ya. Akan tetapi kalau kita baca diskusi lebih jauh, lebih detail, hal ini disebabkan karena pada yang early itu kasusnya lebih severe. Studi yang berikutnya oleh Kian dan kawan-kawan pada tahun 2022 didapatkan bahwa early RRT itu dikaitkan dengan resiko all cause mortality ICU-nya itu lebih rendah. Dan pada tahun 2020 Shen dan kawan-kawan itu menunjukkan bahwa pada kelompok yang dengan early goal directed renal replacement therapy itu angka kematiannya lebih rendah dibandingkan yang late, yaitu 39,1% berbanding 63%. Kemudian studi yang terakhir adalah Zhao dan kawan-kawan pada tahun 2024. Ini menunjukkan bahwa pada kelompok yang early, yaitu pada 6 jam setelah kita diagnosis AKI, itu dikaitkan dengan waktu terapi atau lama rawat di ICU-nya lebih singkat dibandingkan yang tidak early atau standard treatment. Pertanyaan berikutnya adalah tentang modalitas dari RRT. Jadi di sini kita dapatkan ada beberapa studi yang relate. Studi yang pertama itu dengan desain RCT. Jadi di sini didapatkan pada kelompok yang CRRT dibandingkan dengan yang intermittent hemodialisis itu didapatkan rate untuk kematian CRRT-nya itu 54,4%, sedangkan IHD 46,5%. Namun kalau kita baca lagi, kembali lagi bahwa pada yang CRRT itu lebih severe atau lebih berat kondisinya dibandingkan dengan yang IHD. Kemudian pada studi Borbola Flores tahun 2024 didapatkan bahwa pada pasien ICU COVID dengan AKI dan mendapatkan RRT itu kesintasannya 23%. Hal ini menunjukkan bahwa pasien ini sudah dalam kondisi yang berat dan disertai dengan angka kematian yang tinggi. Kemudian studi dari Villa Torres 2023 juga pada pasien COVID-19 dengan pneumonia atipikal ini mendapatkan hasil pada pasien yang mendapatkan peritoneal dialisis atau PD yang akut itu overall mortality-nya 61,7% dibandingkan yang kronik peritoneal dialisis. Artinya dia ada kondisi akut yang menyebabkan pasien ini mesti dilakukan peritoneal dialisis. Jadi kembali lagi ke severity-nya bahwa pasien ini lebih berat kondisinya dibandingkan dengan yang kronik peritoneal dialisis. Kemudian studi yang keempat dari Gusiet Mes tahun 2024 itu membandingkan antara pasien AKI di ICU yang mendapatkan CRRT dibandingkan yang tidak mendapatkan CRRT. Ternyata didapatkan strong iron levels pada pasien dengan CRRT itu lebih tinggi dibandingkan yang tidak dapat CRRT. Artinya CRRT ini mampu mengoreksi dari asidosis metabolik yang dialami oleh pasien. Dan strong iron gap ini bisa dijadikan sebagai prediktor kapan untuk memulai RRT. Ini yang didapatkan dari penelitian ini. Penelitian yang berikutnya dari Koiner tahun 2024. Nah, dia membandingkan antara pasien yang mendapat CRRT dan IHD, dan hasilnya adalah pada yang mendapatkan CRRT itu renal recovery pada saat discharge sebesar 87,2%. Jadi secara klinis cukup berbeda walaupun secara statistik dia tidak bermakna. Studi yang berikutnya dari Kalaria tahun 2024 yang mempelajari bagaimana kinetika dari obat pada akibat pengaruh dari CRRT pada mode CPVH, dan didapatkan bahwa terdapat perubahan dosis atau kadar plasma dari obat ini. Dan ini tergantung dari effluent flow rate-nya. Jadi semakin tinggi effluent flow rate-nya, maka solut yang terbuang yang termasuk dari levetiracetam atau obat ini menyebabkan kita harus meningkatkan dosisnya. Dan ini mungkin juga mesti kita pertimbangkan pada obat-obat lain yang kita berikan pada saat kita melakukan CRRT pada mode ini. Begitu juga pada studi Stasnik, jadi dia meneliti bagaimana sih kadar PTH serum pada pasien yang menjalani CRRT dengan mode CPVHDF. Jadi didapatkan bahwa PTH serum atau parathyroid hormone serum concentration-nya itu menurun pada mayoritas pasien. Pada studi yang berikutnya, yaitu Bowes tahun 2020, pada pasien-pasien COVID di ICU dengan AKI yang mendapatkan PD atau peritoneal dialisis, itu didapatkan hasil bahwa sebanyak 85,2% pasien itu mendapatkan renal recovery. Oke, renal recovery. Dan ini jadi dia tidak dibandingkan dengan yang lain. Jadi hanya pada pasien dengan peritoneal dialisis ini itu kemudian mereka nilai bagaimana renal recovery-nya. Kemudian studi berikutnya dari Piotr dan kawan-kawan pada tahun 2022. Jadi ini studi pada populasi pasien ICU yang sudah stabil, dan mereka membandingkan dengan dua mode ini, yaitu hemodialisis dan hemodiafiltrasi. Dan didapatkan ternyata tidak cukup berbeda bermakna dari kedua mode ini ya, dengan adjusted hazard ratio untuk mortalitasnya 0,85 dan untuk kidney recovery-nya 1,18. Studi berikutnya ini pada populasi pediatrik. Jadi dia memakai suatu SCD pediatrik 01 dan 02. Jadi ini specific cytopheresis device. Jadi ada device tambahan yang berfungsi sebagai imunomodulasi, dan didapatkan bahwa sebanyak 77% itu survive. Nah, pertanyaan berikutnya adalah tentang antikoagulan. Bagaimana studi-studi terakhir terhadap antikoagulan yang dipakai? Nah, studi yang pertama yaitu Kameda tahun 2020 itu menunjukkan bahwa dengan menggunakan antikoagulan nafamospat mesilat itu tidak didapatkan kaitan ya antara umur filter dan juga dosisnya. Jadi ternyata tidak berpengaruh banyak terhadap umur filter. Kemudian studi dari Lau tahun 2023 itu menunjukkan bahwa dengan menggunakan RCA seperti yang akan dipresentasikan oleh Dr. Albert nanti, itu dikaitkan dengan penurunan angka mortalitas. Studi berikutnya dari Kameda tahun 2023 menghasilkan bahwa heparin itu tidak dikaitkan dengan umur filter yang lebih lama jika dibandingkan dengan si nafamosfat mesilat. Oke, pertanyaan berikutnya adalah tentang time to win. Jadi kapan kita mewinning atau menyapi dari RRT ya. Jadi ada 2 studi yang kami ekstrak. Yang pertama dari Thompson tahun 2020. Dia menunjukkan bahwa penggunaan urin NGAL pada jam ke-6 dan kumulatif urin output dengan cut off 210 dalam waktu 24 jam itu dapat menjadi satu prediktor keberhasilan penghentian dari CRRT. Dan studi yang berikutnya dari Zhong tahun 2024, dia menggunakan XGBoost model. Jadi XGBoost model ini adalah model yang diambil dari database, kemudian dibuat AI-nya, kemudian dari situ dinilai ternyata dengan menggunakan model ini cukup baik hasilnya dengan area under the curve-nya itu 0,8 dan validasinya juga cukup baik 0,799. Dan pertanyaan yang terakhir adalah outcome. Bagaimana sebenarnya outcome dari pasien yang mengalami AKI dan mendapatkan RRT? Ya, tentu saja pasien-pasien yang dengan AKI itu biasanya angka kematiannya cukup tinggi ya, bisa mencapai 60%. Nah, mari kita lihat 5 tahun terakhir. Dari penelitian Guo tahun 2020 itu mendapatkan bahwa pada pasien ICU yang terinfeksi HIV itu angka kematiannya 62,5%. CRRT waktu itu dijalankan dengan mode CVV-HDF dengan dose 30 cc per kilo per jam. Studi yang kedua dari Li tahun 2023 ini menunjukkan pada pasien dengan septic associated kidney injury yang mendapatkan RRT itu ternyata penggunaan furosemid ya dibandingkan yang tidak dapat furosemid itu dikaitkan dengan angka kematian yang lebih rendah. Kemudian studi yang ketiga dari Rian tahun 2020 pada pasien-pasien COVID yang dirawat di ICU, itu didapatkan bahwa angka kematian rumah sakit pada pasien tersebut sebesar 60%. Kemudian penelitian dari Salman tahun 2021, jadi dia meneliti mengobservasi ya pada pasien-pasien COVID yang dirawat di 13 ICU di Sao Paulo, ternyata didapatkan angka kematiannya cukup tinggi, yaitu 72,5%. Untuk penelitian di Swiss oleh Salate 2021 dan kawan-kawan didapatkan bahwa pada pasien-pasien yang berusia lebih dari 55 tahun dengan AKI dan dengan RRT dan kita follow up. Nah, ternyata dari pasien-pasien tersebut hanya 7,2% yang renal replacement therapy dependent. Dan pada pasien-pasien yang berusia lebih dari 75 tahun, dia dikaitkan dengan skor kualitas hidupnya yang lebih rendah dibandingkan di bawah atau sama dengan 75 tahun. Kemudian studi di Lituania oleh Vika tahun 2024 pada pasien-pasien ICU dengan AKI yang menjalani RRT itu didapatkan bahwa kadar asam amino yang lebih rendah, kemudian dengan energi expenditure yang lebih rendah, kemudian dengan kadar gula yang lebih tinggi, itu merupakan prediktor yang cukup baik terjadinya mortalitas 30 hari. Jadi sebaiknya kita mempertahankan kadar-kadar ini dalam kondisi yang normal artinya. Nah, kemudian penelitian oleh Wu dan kawan-kawan pada tahun 2021 pada pasien dengan septic associated kidney injury di ICU itu mendapatkan bahwa pada pasien dengan CRRT dibandingkan dengan yang rutin dikaitkan dengan kadar blood urea nitrogen dan serum kreatinin yang lebih rendah. Ya, jadi CRRT lebih baik. Jadi sebagai kesimpulan bahwa sampai saat ini CRRT itu masih merupakan modalitas terpilih pada pasien-pasien ICU yang dengan hemodinamik yang tidak stabil. Akan tetapi karena berkembangnya penelitian-penelitian, oleh karena itu perlu diupdate kembali guideline-guideline yang ada. Nah, sebagai disclaimer bahwa systematic review ini mempunyai beberapa keterbatasan, yaitu populasi yang heterogen, kemudian adanya bias publikasi, kemudian ada studi-studi yang tidak berbahasa lain yang tidak kita masukkan dalam systematic review ini yang mungkin sebenarnya bermakna. Mungkin itu saja presentasi dari saya kembalikan lagi ke Prof. Dita. Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Terima kasih Dr. Mayang atas presentasinya yang sangat sistematik dan jelas ya, komprehensif. Sebelum kita ke topik pembicara kedua, saya persilahkan untuk panitia memutar sekilas video dari Fresenius. Silakan. Thank you. So before the next presenter, the next speaker, Dr. Albert Fu, I would like to read his CV first. From his CV, he finished a Bachelor of Medicine in Hangzhou University, Master of Nephrology in Guangzhou University, and finished his Doctor of Medicine in Ludwig University Freiburg, Germany, and finally finished his Doctor of Philosophy in Chinese University, Hong Kong. He got a lot of awards and a lot of experience, and his current position right now is Director Asia Pacific Global Medical Information and Education, Fresenius Medical Care, Asia Pacific, Hong Kong. So today, he will present his topic about continuous renal replacement therapy with regional citrate anticoagulations with case and data sharing. So Dr. Albert Fu, you may start your presentation.
Thank you very much for the kind introduction, also the invitation, so that I have the chance to share some of the understanding from my side about citrate anticoagulation used in CRRT, and very importantly, also share some of the case or data so that we have better understanding, especially for the complications, because the regular use of citrate already quite proven to be quite efficient and also safe by a lot of data. Just quickly, the disclosure, I'm the Director of Medical Information Navigation from Fresenius Medical Care Asia Pacific. This talk is intended to provide pertinent data to assist your conclusion as well as making your judgment and decision, but not to replace your consideration in the clinical decision-making process. I know that the audience may be quite a big mixture in terms of the experience in using citrate in CRRT. Therefore, I included both the basics from for RCA to be used in CRRT, including the guideline, how it says, and also some of the evidence, including the important studies, but also looking at the protocol general concepts, how the key components, and also using CCAR protocol as an example. I also don't want to miss the chance to share some of the key data and also the tricks, how we can more efficiently recognize the potential metabolic complications, as well as some of the other special scenarios. And after recognition, of course, how we can manage that properly. So starting from the basics, actually, we know before citrate widely used in the world for CRRT, actually heparin is more widely and with longer history to be used for CRRT. However, we can easily understand it's very difficult to find a perfect dose for heparin to be used in CRRT. If too high dose, of course, we increase the risk of bleeding. If the dose is too low, then clotting of the circuit risk is also increased. If we choose one dose in the middle, then the prevention of bleeding or the prevention of the clotting would also not be optimized in the middle. However, on the other hand, the citrates comparing to heparin to be used can more or less achieve that much better way. So quite different comparing to heparin, because citrate not only work as an anticoagulant, but also can be metabolized mainly in liver, muscle, and also kidney to produce or convert to bicarbonate. Therefore, it also impacts acid-base control. So two major functions. But we, of course, use citrate for the anticoagulation purpose. One of the potential reasons why citrate might be even more effective in terms of anticoagulation for CRRT, because citrate chelates or binds to calcium. And as you can see from the figure, calcium is so important and needed in both pathways in the coagulation cascades. And also, we have to know that citrates only prevent coagulation in the regional part, but not in the patient's systemic sites. Sorry for that. Citrates also partially removed from the effluent, and some of the citrate, however, unavoidable infused back to the patient. That's some of the attention we have to pay to understand better why some of the complication may happen. So this is again to look at it again to understand how it works. So citrate normally will be infused step 1 into the circuit very close to where blood taken from the patient so that it can bind to calcium, and much lower ionized calcium in the circuit will efficiently prevent coagulation. That is about the efficiency. And the target normally would be, for example, as low as 0.3 millimole per liter. And chelating to calcium, it forms a citrate calcium complex. This is, however, partially removed into the effluent fluid. That's the major reason why we need calcium replacement fluid to be infused back to the patient. You can imagine citrate was also used for transfusion, the blood to be transfused to the patient. We normally don't mandatory or routinely give calcium because during that transfusion process, no calcium is removed. However, continuous 1 day or several days CRRT, we will lose a lot of calcium through removing citrate calcium complex. Therefore, calcium continuous replacement will be needed. And on the right side, you can see to monitor the systemic ionized calcium back to normal. This is very important for the safety of our patient. So knowing those basics, we will not have sufficient time to go through all the studies, but at least the major studies included. For example, the second reference is one of the biggest RCT to compare citrates to systemic heparin use. This is a study done in Germany, 26 sites included into this study, around 600 patients enrolled. And also the first reference and the fifth reference are also the most important meta-analysis to tell us, collecting all the previous RCTs, regardless small ones or big ones, to see how exactly citrates different compared to heparin. But to summarize, the two major benefits. The first one is reduce the bleeding risk comparing to heparin. From the concurrent meta-analysis, we can see that the risk of major bleeding for RCA is only 22 per 1,000 patients. However, in heparin used in 1,000 patients, there are more than 100 patients experiencing major bleeding. Bear in mind this 22 in citrates. We cannot say these 22 are caused by citrate. As we mentioned earlier, citrate will only work as an anticoagulant in extracorporeal circuit, but not systemically, because those 0.3 or even, let's say, 0.4 or 5 would be so difficult to reach in the systemic level. Even only 0.8 is already a level that the patient may develop a life-threatening cardiac adverse event. So really, it's only work in the regional level. The other major benefit, of course, is a prolonged filter patency compared to heparin. Either this meta-analysis or the biggest RCT tell us the similar number is generally RCA. Citrates will have around 15 hours longer patency comparing to heparin used. Well, longer filter patency also have additional clinical benefit. For example, we can easily understand less filter exchange will be needed, so downtime and also circuit exchange will be reduced. Eventually, nurse workload will be also reduced. On the other hand, for the patient, we know that the prescribed CRRT dose versus the delivered CRT dose, normally there would be a gap, let's say 15% or sometimes even higher than 20%. So in case we are using citrate, normally this gap will be quite minimized so that how much we prescribe for the patient, majority of those can already be successfully achieved. So although a lot of the previous data shown is quite more recent, but more than 10 or 20 years ago, KDIGO guideline already tells us whether or not the patient with or without increased bleeding risk, they are suggesting to use citrate anticoagulation instead of either heparin or no heparin. But one of the conditions is that we know the patients don't have obvious contraindication for citrate. We will touch this a little bit later. What patient group might be considered relative contraindication to citrate, those generally shouldn't be seen as absolute contraindications. So just go through some of the basic components for RCA protocol, taking CCAR protocol as an example. I bring this paper to the slides confirming again the potential benefit of reduced bleeding risk as well as prolonged circuit lifespan. However, one of the message from this paper also telling us not all the citrate protocol are equally effective, especially if we look at the figure on the right. We can see RCA protocols can reach filter life either more than 3 days, some very commonly more than 50 or 60 hours, but some of them around a little bit longer than 1 day, let's say longer than 25 hours. So really not all the protocols are the same. So what are the major components for RCA protocols? What I am showing here is the conventional CRRT. So it's very simple for us. The major target for us is to remove the fluid and the toxin from the patient. Therefore, our ultrafiltration is one major flow rate we have to set, as well as blood flow rate and dialysate flow rate. That's more simple comparing to than citrate. However, we know the benefits. We want to use citrate that will have regional anticoagulation effect. We also have to admit sometimes the machine, if that is not specifically designed for citrates, then the blood flow rates, whenever there's any change, would also impact the anticoagulation efficacy, because the fundamental impact how anticoagulation works is citrate dose. Means, for example, in 1 liter of the preceded blood, how many minimal citrates contained there. So therefore, if we change the blood flow rate but not changing the citrate flow rate, the dose of citrate will be changed. The anticoagulation effect will be different. On the other hand, we know for the patient safety, calcium replacement will be needed. However, the other factor, the dialysate flow, will also potentially impact that as well, because if we, for example, increase dialysate flow rates, more citrate calcium complex will be removed, so that less CCC will be reinfused back to the patient, which will be converted also to release those RNAs calcium to the patient. So this will also impact how much calcium the patient eventually will get. We mentioned the second function from citrate that is also impacting acid-base status. And 2 additional flow will also have impact to acid-base because citrate is a potential buffer. If we, for example, increase blood flow rate and that machine coped citrate flow to blood flow rate, then in this case, citrate flow rate may also be increased. So more buffer will be infused to the patient. If we increase dialysate flow rate, on the other hand, we increase the removal of citrate, right? But then citrate back to the patient converting to bicarbonate will also be reduced. So you can see how complex that could be. At least 3 of the goals substantially depending on 2 or even 3 flow rates. So how to simplify this? For example, we are more focusing on dose instead of flow rates in terms of citrates or calcium replacements. In this case, anticoagulation will not be impacted by blood flow anymore because the machine will automatically adjust because we only enter into the machine how much citrate dose I need. Whenever we want to change the blood flow rates, the machine knows the dose should be maintained fixed. So the citrate flow rate will be proportionally adjusted according to the blood flow rate you want to change. Similarly, calcium replacement dose will be fixed. That is different. We describe it calcium, how many millimole per liter of effluent, because how much calcium we remove from effluent we want to replace, right? Whenever we want to change, for example, dialysis flow rate, the machine knows you have a fixed dose for calcium. Then if you increase the dialysis flow rate, then calcium removed will be increased. So calcium dose will also be adjusted. Calcium dose fixed, but calcium flow rate will be changed accordingly as well. So back to the CCAR protocol, there are only 3 major monitoring as well as initial setting to bear in mind. That's the major that we won't forget. So it will be very easy for us to apply citrate to our patient. The first one is about citrate dose. We set it initially 4 millimole per liter preceded blood. In this dose, majority of the patient will get sufficient anticoagulation. And we will monitor that every, for example, 8 hours, see whether the post-filter ionized calcium concentration is in the range. Let's say this is taking CVVHD as example. So the target range, we set it 0.25 to 0.34. If that is any deviation, depending on that is mild or big, we will according to the figure in the middle to adjust the citrate dose by 0.1 or 0.2 millimole per liter. And we will change that, and after another 8 hours, we will see whether or not it goes to the target range. Of course, if clinically you see additional measurement is needed, you can make those decisions according to the patient's need. The second is about the patient major safety issue is to keep the calcium infusion dose. Initial dose will be set 1.7 millimole per liter effluent fluids flow rate. And around every 6 hours, we will check the systemic ionized calcium. That is talking about patient safety, right? This is a systemic ionized calcium. The target will also be different. This is 1.12 to 1.20. And whenever there's deviation, depending on that is mild or big, so we will change the dose in the step of 0.2 or 0.4 millimole per liter to change the dose and to monitor that also ongoing throughout CRRT. So the third one or the last one, we have to bear in mind, we have initial setting, means the dialysate over blood ratio. We have to set it more or less fixed. Either if we take the same flow rates unit, say, then it will be 32%. If we take the units we are using in daily base, like 100 ml per minute blood flow rate and 2000 ml per hour dialysis flow rate, then might be a little bit easier. We just know that is 20 to 1 as a ratio, but the unit is different. We bear this in mind. So taking this initial setting, majority of the patients will get eventually satisfactory acid-base condition well controlled. Acidosis, if at the baseline, will be well controlled. However, if there is any deviation, it's not satisfactory after 1 day or more, you think that is too slow or too fast towards alkalosis, for example, you can change the ratio to correct that in a way, for example, in the step of 20% change, either change the dialysate or change the blood flow rate. One of the example I have given already on slide is, for example, if we have a patient acidosis continuously not well corrected, so we can imagine acidosis. We don't have sufficient bicarbonates in the patient. We need more. So currently, the alternative is to give more citrates infused into the patient. How we can achieve that? Simply increase the blood flow rate. We will get more citrate infused into the circuit. Even some of them can be removed by the effluent, but still infused back to the patient. Citrate will also be increased. That will be converted into bicarbonate. On the other hand, if the patient's baseline acidosis is too mild, after 1 day, it's very soon corrected even towards the alkalosis trend. What we can do easily is, for example, because currently the citrate infused into the patient is a little bit too much, depending on the acidosis condition for the patient. Therefore, we want to, for example, remove more citrates from the effluent. Then we can simply increase the dialysate flow rates. Alternatively, of course, we can decrease blood flow rates. We don't have the fear that anticoagulation effect will be impacted because the citrate dose enter into the machine is fixed. So the dose is not changed, but accordingly, citrate flow rates will be automatically changed by the machine. So knowing all that, majority of the patients may be well monitored and they get very satisfactory acid-base condition post-RNAs calcium as well as systemic RNAs calcium, indicating citrate dose as well as patient safety of calcium level is all fine. But sometimes if very small chance patient develop metabolic complications, we have to recognize that and also manage properly. Just to quickly let us understand why we might have different solution to be used when we use citrate for CRRT. So we use the bicarbonate here I show is for CRRT not using RCA. But if we use citrate, we infuse the citrate into the circuit, and partially it will be removed by the effluent. The rest will infuse back to the patient, normally quickly metabolized in liver, kidney, or muscle. And therefore, the solution to be used together with citrate, the bicarbonate concentration comparing to the other commonly used CRRT solution will be lower. For example, the CCA solution will have bicarbonates concentration 20 versus a multi-big has the bicarbonate concentration, for example, 35. That's the reason, because citrate infused back to the patient will be converted into bicarbonate. However, we know that some of the metabolic complications still will happen, especially the second two. They are not talking about citrate dose is wrong. The citrate dose is fine. The patient got good anticoagulation, but because the patient baseline condition in terms of acidosis is different, so how much we prescribe, let's say 4.0 millimole per liter citrate dose, for this patient, either some of the patients may feel the citrate infused is too much, they might be more easily develop alkalosis, or on the other hand, if the patient at the baseline, for example, they have much more severe acidosis. Even after 1 day, they still cannot be well corrected, so that we may expect more citrate to be infused. We call it insufficient citrate delivery for the third one, but citrate net overload for the second one. Nevertheless, these two are still much more easy to be managed. Simply change the dialysate flow rate or blood flow rate according to what we mentioned, to change the ratio, not 20:1, but to change one of them by 20%. However, one of the potential most concerned is citrate accumulation. What is happening for this patient? They have lower metabolism of citrates in their body. So the so-called citrate calcium complex, even some of them removed by effluent, but some of them refused back to the patient. Normally for the other patients, they are quickly metabolized, converted into bicarbonate and ionized calcium. In this patient group, however, they will not be released and they will maintain much longer, so that the patient expected the increased ionized calcium as well as increased bicarbonate from this complex will be stopped. So for this patient, they will eventually develop acidosis together with hypocalcemia. And we know this complex still contains calcium, so the total calcium concentration will also be increased. That's one of the major reasons. We also, if we talk about citrate accumulation, we also talk about a ratio, a total calcium to ionized calcium ratio. If that is higher than 2.5, it's really highly suspecting the patient might have citrate accumulation. Some doctors might be more sensitive and want to get early alert so that they may take different number, say 2.25 instead of 2.5. And as you also can see, the mechanism of these three are different. The second two are more easily to be handled, and the calcium for those patients normally still okay, but they have acid-base issue. But for the citrate accumulation, they have both acid-base issue as well as ionized calcium decreased in systemic level. And this, of course, if the doctors and nurses are following the protocol, we are also, in this case, to increase the calcium dose, right? This is also one of the potential signs. We see continuously increased need of calcium replacement. This is also a warning sign for us to ask the question whether or not the patient has citrate accumulation. If that is mild, still can try changing the blood flow rate and the dialysate flow rate, whether that can improve. If at the end is not possible, we have to change to alternative anticoagulations. So we may not dive too much into details very quickly. So one of the REACH study we mentioned, the biggest, they take liver failure patients, shock patients excluded from the study because they really think the patient might have higher risk of citrate accumulation. Whether or not liver failure is really contraindicated, actually some of the meta-analysis collected 10 observational studies, more than 1,000 patients. If we look at the comparison, end of CRRT versus baseline, increased ratio of total to ionized calcium is only minimal, is 0.1. And also citrate concentration is no significant increase in the serum. More importantly, 2 of the studies are, among these 10 studies, they also comparing liver failure versus non-liver failure patients. And they have found no significant between, for example, the groups in terms of lactate level, or pH, as well as total to ionized calcium ratio. So to conclude, they tell us that citrate still can be safely used in CRRT for liver failure patients. Of course, we need careful monitoring and strategy adjustment. However, which criteria to use is also an open question, because where the CRRT protocol developed, that is from Germany, the CRRT hospital in Berlin. One of their criteria might be using not only looking at the ratio of total to Arna's calcium or 2.25, but they are also looking at the potential decrease of systemic Arna's calcium lower than 1.1, as well as the relative metabolic acidosis lower than 7.2 for pH, as well as the base exceed lower than -5, and also elevated A9 gap higher than 12. So they also go back to the meta-analysis and say majority of the studies actually only use one of the criteria, but not four of them. For Berlin, they identify positive if 3 of the 4 items got positive. So that they think the citrate accumulation incident reported in those studies could be overestimated. At least for Berlin, they normally see, for example, the incident around 3%. For this 6 ICU, more than 1,000 patients, they think sometimes it's not only liver. For example, in this case, it might be more important to recognize this is not liver failure, but rather therapy-resistant shock with severe lactate acidosis. This reflecting the severe intracellular hypoxia. And this 30 plus patients developed among 1,000 patients running citrate. 3 years later, they published another paper, very important for us to understand, because the baseline lactate might be important, but not so sensitive. They took the group into 2, and baseline lactate lower than 4 or higher than 4, they still cannot be sensitive enough to indicate the risk of citrate accumulation. However, the trend along the CRT, whether or not lactate is increasing, is more important to impact the final occurrence of citrate accumulation. So this slide is very important for us to understand the early sign citrate accumulation. I just point to the major points. The 0 hour is the time clinically to diagnose citrate accumulation. And the 1.5 day earlier, ionized calcium decrease, as well as the increased calcium dose demand is the earliest sign. Together with lactate increasing trend, this is roughly 1 day before. Acidosis, significant change happened only half a day. So generally they see the increased need of calcium replacement together with the ionized calcium decreased systemically, together with lactate dynamic increasing is the early signs for citrate accumulation. So clogging is another also very rare condition, but in COVID, we may encounter quite often. It's different comparing to clotting, because clotting, the blood cannot flow through the fiber anymore. But for clogging, the blood still can flow through, the circuit still can run, but the thick membrane coating is significantly impacted the permeability of the membranes. So that if that is running for CRRT in general, creatinine removal, for example, will be impacted. But if we are running citrate, the CCC complex will be less removed. Eventually, alkalosis as well as hypercalcemia will be observed because all the CCC much more reinfused back to the patient, and calcium replacement dose will be reduced because the ionized calcium will be increased. I will jump this maybe very quickly because alkalosis is one of the signs. But on the left side, if the filter is working quite well, if we are having alkalosis for this patient, then we are suggested to increase the dialysis flow rate to remove the citrate more, so that the bicarbonate will be less infused into the patient, converted from citrate. But on the right side, if the filter clogged, so the CCC will not be efficiently removed. Eventually, those will be infused more into the patient. Alkalosis as well as hypercalcemia will be observed if we are using high concentration citrates, 4%, for example. Sodium concentration might also be impacted here. So I may jump this, but very importantly, the major observation for them is alkalosis. As you can see, hypercalcemia, reduced calcium dose, as well as increased sodium are the major ones. Even the adjustment according to the protocol cannot correct the alkalosis. This is more important to see. And this is just the figure. 0 hour is the time clogging trigger the filter exchange. The management for clogging, we have no other choice. We have to change the filter. What we have seen is alkalosis, increase the sodium, ionize the calcium systemically, and also reduce the calcium infusion rate. So comparing to the other complications, clogging is very different. Some of the patient condition cause thicker membrane layer on the membrane, so that the removal of CCC is reduced, and more CCC going back to the patient, causing alkalosis and hypercalcemia. So already quite some of the complication. I just want to share this very personally. I think by this very simplified and differentiation or science, we can easily differentiate different complications. In the middle, if calcium level is okay, it's only acid base, so the patient acidosis issue then is either related to the patient need of the buffer. Is citrate insufficient, or is the citrate overload to the patient? However, more concern we might have citrate accumulation, not only in acidosis, but also reduced ionized calcium systemically. On the other hand, clogging is the other direction. Alkalosis combined with increased ionized calcium systemically and reduced dose of calcium replacement. So to summarize, RCA suggested by KDIGO has wide range of benefits, mainly reduced bleeding risk and prolonged filter life, but also quite safe for majority of the patients. Well-validated protocol has clear guidance. It's important to be providing reliable performance. Some of the complications we mentioned, the details. One of them we might not have time within 20 minutes to cover is clotting despite RCA. That's more or less associated to the heparin-induced thrombocytopenia type 2, and the major management is use direct thrombin inhibitor to help for those cases. Thank you so much. I will stop here, see any question and discussion needed.
Thank you so much, Dr. Abetfu, with a very, very clear and comprehensive explanations. So now we start for the question and answer sessions. So we already received several questions for both speakers, yeah. One of the questions that maybe can answer both by Dr. Mayang and Dr. Albert, the panelists ask, when we can choose another modality, for example, like for intermittent hemodialysis or even peritoneal dialysis. Maybe Dr. Mayang first can answer.
Okay, thank you for the questions. Okay, we know that there are several modalities of RRT, and we choose principally based on the condition of the patient. Jadi berdasarkan kondisi pasiennya ya. Jadi kalau misalnya pasien itu bisa rawat jalan, maka kita bisa memilih untuk memakai peritoneal dialisis atau CAPD. Tapi kalau misalnya pasien itu masih perlu dirawat inap, artinya pilihannya ada 3 nih, yaitu intermittent hemodialisis, ataukah SLED, ataukah CRRT. Nah, pemilihan dari 3 ini tergantung dari hemodinamik pasiennya. Jadi kalau misalnya pasiennya itu hemodinamiknya stabil, maka bisa memilih yang intermittent hemodialisis yang rutin dilakukan oleh nefrologis ya teman-teman kita di ruang HD. Nah, tapi kalau pasien itu dalam kondisi tidak stabil hemodinamiknya, maka kita pilih apakah dia yang low support, low vasopressor, jadi cut off-nya yang saya baca adalah 0,1. Jadi kalau misalnya dia di bawah 0,1, kita masih ada tempat untuk melakukan HD SLAT. Jadi yang low, slow, dan low efisiensi dialis atau SLAT ya. Nah, tapi kalau misalnya dia tidak stabil, kemudian perlu dosis vasopresor yang tinggi, lebih dari 0,1, maka tepatnya adalah CRRT. Mungkin begitu, Prof.
Terima kasih Dr. Mayang. Dr. Albert, maybe do you have any comment?
Yeah, sure. I can quickly add on that. For example, at least I think PD can also be modality that can also support patients in unstable in terms of hemostability conditions. However, that generally needs much more support from the others, especially a good team needs to be available very timely, because CRT to be started by our staff is much easier comparing to PD, urgent start PD to support. However, if the hospital and the relative specialists are always ready and have a good collaboration, that can still be manageable, especially COVID time. I believe, especially in the United States, I have seen a lot of reports. They simply don't have sufficient CRRT device as well as intermittent HD device, so that they have to start PD saving those COVID patients with AKI as well. So their program also was successful, but they need additional staff support. In terms of intermittent HD, of course, for the stable patient, I think especially if they need faster removal of certain toxins for example, like toxicity patient, or some of the potassium level quickly need to be corrected. If the patient are stable, might still have some advantage. But in ICU setting, I think CRT might be sufficient to support the majority of the cases needed. Yeah, thank you.
Thank you so much. We move to another questions. Our participant asked, can we perform citrate anticoagulant in CRRT in severe liver dysfunctions or a severe lung problem like COPD? Maybe Dr. Albert can answer.
Okay, so we mentioned liver failure is a relative contraindication. I haven't mentioned the other 2 scenarios. For example, in the United States, there are a group of doctors. They developed a so-called shock protocol. They apply that for all patients, including severely liver failure patients, very successfully. They reduced the blood flow rates and dramatically increased effluent, especially diffusive, not convective. So dialysis versus filtration is 5 to 2. So they are depending on diffusive more than convective, and blood flow rate as slow as possible. In this way, they remove the majority of the citrate from the circuits. All of their patients don't experience citrate accumulation. However, if we are talking about respiratory patients on ECMO and so on, I think that's really add additional complexity, especially in terms of acid-base control and so on. But I think if the group already are quite experienced in managing, adjusting the blood flow rate, dialysis flow rates, and also looking at potential adjustment of the citrate dose and closely monitoring, I think is still manageable. Comparing to the citrate accumulation contraindication, I think respiratory is rather less a concern for citrate used in CRRT. Yeah.
Thank you, Dr. Albert. I mean, in
Thank you.
Indonesia, we can monitor the calcium level or taking blood gas analysis frequently, but it's not
Right.
common to measure the citrate level. Is it
Exactly.
is it
That's a
necessary?
great.
Is it necessary, or do you check routinely when you use citrate?
Yes, I think that's a great question. So first of all, ionized calcium measurement, we have to always bear in mind two levels are needed. Post-filter level, our target is very low, and the systemic level is actually more important in terms of patient safety. That is in a rather normal range for majority of the rest of the patient group. So some of the kits in the market might not be good enough to measure accurate post-filter ionized calcium level, might have some impact to adjust the citrate dose, right? But there are also studies to show different kits might have different accuracy in terms of measuring that. But the Berlin group published another paper saying the post-filter ionized calcium level, how important, how necessary to be closely monitored. They look at the data and eventually a little bit deviation around the target range. I mentioned 2.25 to 2.34. If there is a deviation, still the association to the filter life is not so significant. So at the end, they are also questioning whether or not we can reduce the frequency to monitor the post-filter ionized calcium. However, for the patient safety and also the commonly used kits for blood gas analysis should be accurate to measure systemic ionized calcium. I think that is most important for patient safety and adjustments. That's a great question. Thank you.
Thank you. So maybe the last questions for both of the speaker. I believe that Dr. Mayang and Dr. Albert also perform intermittent hemodialysis in the ICU, yeah. So there is a question whether the citrate anticoagulations can be used for intermittent hemodialysis, because we know some of our ICU patients cannot tolerate heparin during the RRT. So maybe Dr. Mayang want to give a comment first?
Yes, thank you, Prof. Dita. Thank you also for the questions. Yes, actually there are several anticoagulants of choice that we can use. But in our daily practice, actually we can use heparin as our first choice because of they are easy to get, it's cheap, and there is also an antidote, yes, like protamine, yeah, that we have in our hospital, and it also has a short half of life compared to like enoxaparin and others. But we know that there are some cases that we can use heparin, and then we can use citrate as our alternative of anticoagulant. maybe Dr. Albert has very a lot of experience using citrate, but by this presentation, we know that we can use citrate also as our other choices of anticoagulant. Maybe that's from me, Prof. Dita.
Thank you, Dr. Mayang. Dr. Albert, do you have any comment about using citrate for the intermittent hemodialysis?
Thank you for the question. So first of all, my personal practice using this not only for CRRT, but also for HD and HDF. That was actually more than 20 years ago in my previous hospital in Wuhan, although a lot of practice not common at that time. But I really was impressed. Although I have to admit, the citrate benefits for CRRT is very impressive and also suggested by the guidelines, but citrate to replace heparin, like Dr. Mayan mentioned, the majority of the patients can already be managed by heparin well. And also in terms of no heparin for 4 hours intermittent, I think comparing to 24 or even 72 hours in terms of CRRT, the need of very strong anticoagulant is much lower in the intermittent HD compared to CRRT. Nevertheless, I still tried citrate to treat some of my previous chronic HD patient or even acute patient, but in intermittent way, because some of the patients simply cannot get sufficient filter patency during 4 hours, even clots within 2 hours. That's too troublesome. I remember one of the patients was multiple myeloma. That patient has very thick blood, very easily to clot. We used a very high dose of heparin, still clot very easily. So eventually we tried citrate. We haven't adjusted the dialysate composition in terms of bicarbonate concentration, calcium. Namely, we are using calcium-containing solutions, dialysate, the commonly dialysate. But adding citrate really dramatically improved the filter life. 4 hours, no issue at all for those patients. But I believe we can, depending on the patient needs, majority of patient can be managed by heparin or no heparin just by saline flushing. But a very rare condition, patients really don't have very good filter patency within short period of time. Citrate still can be used, but that my previous protocol was more than 20 years. I think we can quickly check how the protocol might have been improved and adjusted. I think still alternative to manage difficult patients population. I believe so. Yeah.
Thank you for the answer. But we also have to be careful with the level of the calcium, during and after the procedure. Thank you. So finally, we are in the end of our webinar. So as we get the better understanding and familiarity with the renal replacement therapy and CRRT with different anticoagulant, either heparin or citrate, hopefully we can improve the management and the outcome of our patients in the ICU, especially with the AKI. Thank you for all the speakers for a very great presentations and a very great answering the questions. Thank you so much. See you next time. Thank you.
Thank you.
Thank you, Prof. Dr. Albert.
Yeah.
See you next
Thank
time.
you. See you
Thanks.
next time. Ya. Saya kembalikan kepada panitia. Terima kasih.
Baik, terima kasih kepada Profesor Dita, Dr. Mayang, dan juga thanks to Dr. Albert Fu, sekaligus kepada peserta yang telah menjadikan webinar ini penuh dengan ilmu dan diskusi yang bermanfaat. Semoga apa yang kita pelajari hari ini terkait dengan Management of Acute Kidney Injury in ICU, focus on continuous renal replacement therapy using regional citrate anticoagulant dapat diaplikasikan dalam praktis klinis sehari-hari. Kemudian mohon maaf apabila jika ada kekurangan dalam webinar ini. Terima kasih atas partisipasinya dan sampai jumpa di kesempatan berikutnya. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Thank you so much, Dr. Albert, Dr. Mayang, and Dr. Erwin. Thank you. See you in the next
Thank you.
webinar.
Thank you so much.
Thank you. Terima kasih, Mbak Mega, Fresenius.
Terima kasih, Prof.
Thank you. Terima kasih.
Bye-bye, Prof.
Bye-bye.
Thank you.
Bye-bye.
Mbak
See
Mega,
you.
Dr. Erwin.
Izin
you.
leave.